Okay, so we are going to discuss melanoma today. And just as an introductory comment, melanoma is extremely heterogeneous, complex, and we cannot cover everything that's relevant to melanoma in this one brief lecture. So keep that in mind. If you find anything of interest among the discussion, definitely you'll want to supplement your reading with additional resources and updated literature review and journal articles. Again, I'm Jeffrey McBride. I'm the Director of Dermatopathology in the Department of Dermatology at the University of Oklahoma. Melanoma represents about 5% of skin cancers, but unfortunately leads to about 75% of skin cancer deaths. The incidence rises with age. It is present in children. It's rare, fortunately. However, unfortunately, it still comes up in children. Third most common cancer in young people, actually. About 2/3 of melanomas arise de novo, and about 1/3 develop within an atypical or benign nevus. Risk factors include sun exposure, blistering sunburn during childhood, fair skin that burns easily, a personal or family history of melanoma, large numbers of nevi, especially of greater than 100 on count, and the presence of atypical nevi. So a little bit about the biology of melanoma. Progression occurs in 3 clinical pathologic stages. First, you have radial growth. You can see melanocytes starting to proliferate along the dermal epidermal junction. You'll have foci of pagetoid upward migration. You'll have melanoma cells that are actually touching each other, and this is just in one 2-dimensional plane. So you can imagine the entire 3-dimensional interface here is completely filled up with contiguous growth and pagetoid upward migration in this cartoon. So that's the radial growth phase. The vertical growth phase, as you would imagine, begins when the melanoma cells start to dive deeper into the dermis here. So you can see that at some point, there is no significant radial process anymore. It's really about downgrowth into the dermis there. And unfortunately, metastasis is when these cells find a way to spread into the lymphatic system and travel to the lymph node, often the sentinel lymph node areas. And that's where you have your procedure to try to detect metastatic melanoma with a sentinel lymph node biopsy. Melanoma in situ is definitionally melanoma that exists within the epidermis only. So you can imagine radial growth phase. It's only staying in the epidermal compartment. If you have even a small focus of melanoma in the dermis that is not just a reedy ridge cut out of section, but in true an actual separation from the overlying neoplasm there, you'll have to measure that as an invasive. This can be very tricky, and oftentimes dealing with an MIS or a super thin melanoma, practically speaking, is not going to drastically change management because you're still going to have an excision of the specimen. If there is a little bit of an invasive component, then the surgeon may take more margin. If it's on the face, for example, then you may actually have to refer over to plastic surgery or some other type of excisional methodology, because Mohs surgery oftentimes may want to avoid any invasive melanoma. However, most melanoma in situs are diagnosed, and later on when they're excised, even in Mohs, there's a debulk section, and the pathologist is often tasked to look for invasive disease. So dermatologists and dermatopathologists understand that if something's called MIS, it may turn out to be invasive melanoma on excision. Oftentimes, MIS does track down adnexal structures, and those adnexal structures can become quite deep as well. And you can have bulbous proliferation of atypical melanoma nests going up and down the adnexal structures. And while it looks almost invasive, it's still hugging to the adnexal structures. So we'll take some look at some examples of that, but for definition purposes, melanoma in situ stays within the epidermis. There's no dermal invasion that is known on the slides. Excision is thought to be curative because, again, you're removing all of the melanoma. There are 2 major types. There's Lentigo Maligna type of melanoma in situ, and then there's the traditional MIS, which is sometimes referred to as superficial spreading MIS. If someone says MIS, though, they can be referring to traditional MIS or Lentigo maligna type. These typically vary based on the growth pattern. So usually Lentigo maligna just has very contiguous growth on the head and neck of sun-damaged patients. There's a prominent radial growth phase. Superficial spreading melanoma in situ, which don't confuse that with superficial spreading invasive melanoma, that just refers to the traditional contiguous growth and pagetoid spread in other parts of the body, not necessarily on the head and neck of sun-damaged skin. There are oftentimes different genetic aberrations that may be found on molecular testing. However, this is in practicality and for cost-saving purposes not often done. So Lentigo maligna subtype, as we talked about, usually occurs on the sun-damaged skin of elderly patients, usually on the face. And if you have melanoma in situ on the face, it's most likely Lentigo maligna type. It's usually a very broad lesion, so I'm always amazed when I see the wall-to-wall contiguous growth along the dermal epidermal junction going down adnexal structures and just on and on and on from east to west on the biopsies. It's quite striking. Here's an example of melanoma in situ Lentigo maligna type. So you can see that this patient has a background of well-defined seborrheic keratosis, maybe some small junctional nevi or compound nevi, a lot of sun damage here, a lot of solar elastosis you can imagine is going to be present on the biopsy. But in the center is where you have this variable, ill-defined brown patch. It's pretty much bigger than 1 centimeter. Some areas may be more of a papular plaque because if you close your eyes, you may be able to feel the pathology there. And it's oftentimes very impractical to try to shave this entire lesion off the skin. And so what will end up happening is clinicians will look with their dermatoscope or try to identify areas that have more than 3 colors clinically and dermoscopically and try to go after what looks to be more malignant and do a broad shave. A broad shave is very helpful because you're getting most of the epidermis, and we can cut multiple sections and take a look at as much epidermis as possible. And there are some immunostains that often help me when I'm getting a lot of melanocytic hyperplasia. And I want to separate out melanocytic hyperplasia versus true melanoma in situ from an immunohistochemical standpoint. And we'll talk about those stains later on in the lecture. Again, with Lentigo maligna, it's a broad lesion on sun-damaged skin. Typically, it results in effacement of the rete. So if you see a biopsy with very atrophic, thin epidermis with no rete ridges, you should become concerned that this could represent a Lentigo maligna. And if the clinician was worried about melanoma and you have abundant solar elastosis with a atrophic epidermis, loss of the rete ridges, and abundant melanin pigment, or even without abundant melanin pigment, I find it's useful to do a SOX immunohistochemistry stain to just make sure that we're not dealing with a Lentigo maligna. I often do a PRAME stain on these cases as well, and I'll get to the relevance of PRAME stain in a few slides from now. So what does Lentigo maligna show? It shows atypical melanocytes in a lentiginous distribution. You can see some skip areas, and that makes it diagnostically challenging if you're just relying on one representative piece of the epidermis. And so you really have to find ways to make sure that you're not missing contiguous growth that is truly a Lentigo maligna. And I find that doing multiple sections as well as the immunohistochemistry helps out. Atypical melanocytes extends down adnexa. You may have junctional lentiginous and limited pagetoid spread. And that's the thing beginners don't realize about Lentigo maligna type is you don't have to have a lot of pagetoid spread to make the diagnosis. By definition, there is no invasion into the dermis. So finally, we get to some pathology. Here we have a contiguous growth of atypical melanocytes along the dermal epidermal junction. You can see the nuclear pleomorphism among the melanocytes. The melanocytes stick out because they have this prominent halo artifact with this strandy material around the nucleus. and no surrounding desmosomes. However, nowadays, I usually like to sign out my reports with at least a SOX to confirm the extent of contiguous growth or pagetoid upward migration, especially on the head and neck of patients with severely sun-damaged skin, if it is a subtle or borderline case. However, this picture alone is clear that there's a melanoma in situ here, and you could just go ahead and make this diagnosis without any ancillary testing. You can see the loss of reedy ridges here. It's a great example of atrophic skin, abundant solar elastosis with contiguous growth and focal pagetoid upward migration, even in this Lentigo maligna type. On higher power, you really see the striking atypical cytomorphology of the melanoma cells here. Again, more good examples of just that contiguous growth, pagetoid upward migration along the dermal epidermal junction. Now, if there was any question that this was, let's say you got only a piece of this and the clinician was very convinced that this was probably a Lentigo maligna, is there a stain that you could do that would most likely highlight diffusely positive? So SOX10 would mark all normal melanocytes as well as melanoma cells. There is some evidence that PRAME, which is basically an abbreviation for the long name of preferentially expressed antigen in melanoma, or PRAME, is diffusely expressed in atypical melanocytes in most melanomas, upwards of 95% or more, based on retrospective analyses. And in my hands, it correlates almost always with the H&E staining. There are some rare exceptions both ways. However, it is a good confirmation tool, or at least a screening tool in many cases, which we'll get to. So superficial spreading melanoma in situ, as we mentioned, these are often broad lesions with junctional nests of atypical melanocytes. Pagetoid spread of the nests are often seen, so not just single cells, but the actual nests as well. Nests may extend down adnexa, and that's kind of one of the diagnostic hallmarks. Again, no invasion is seen. That's the definition. And interestingly, there's not always an abundant solar elastosis component here. So you can have MIS on young people and not very sun-damaged skin, essentially anywhere. And so it doesn't always rely on previous abundant sun damage and solar elastosis. Here's an example of a proliferation of nests and single cells throughout the epidermis and along the reedy ridges. Prominent pagetosis here. This is a melanoma in situ. Again, higher power view showing melanoma in situ. Now, let's say that you didn't have clinical information, or you wanted to make sure that you weren't dealing with another type of pagetoid entity. You'll want to definitely make sure that you're not dealing with a pagetoid squamous cell by doing a P40 or a P63. You'll want to make sure that these are truly SOX10 positive and PRAME positive. I find it useful to get a PRAME just to understand which melanomas are PRAME positive or PRAME negative for future prognostication. Oftentimes, of course, these will be Melanoma positive, but you'll want to confirm if someone's worried about a Paget's disease that these are not positive for CK7. And other entities that can show pagetoid diffuse spread would be if you were looking at a mycosis fungoides. However, these don't look like lymphocytes, but of course, you could do a CD3 just to make sure that these are not lymphocytes. Again, this probably was sent in as rule out melanoma, and that's what it is. It is a melanoma. But just for academic discussions, what other things would you want to consider for pagetoid spread? Again, what helps you know these are melanocytes? Abundant pigment production here in the atypical melanocytes. You'll see that the level of pagetoid gets up into even the granular layer as well. The immune cells are definitely reacting. So the lymphocytes know that this is a malignant process, and they're basically trying to kill or react to the melanoma. Moving on to invasive melanoma. Invasive melanoma is where it starts to get dangerous for the patient. So architecturally, this is atypical proliferation of melanocytes, essentially melanoma cells in the epidermis and the dermis. This is kind of where we get beyond the radial phase into the vertical phase that we talked about. The histologic features suggestive of malignant melanoma include overall asymmetry of proliferation. So you want to contrast these findings from the benign lectures that we've posted here, where you're being able to say something is a melanoma or is not a melanoma. One of the things that you're going to be assessing is the overall symmetry of the lesion. So if it's very asymmetric, that argues for melanoma. If you have a loss of the basement membrane integrity, essentially the melanoma is consuming the normal architecture of the epidermis. That supports malignant melanoma. The more mitotic figures you find in dermal melanocytes, that becomes a very big red flag. You can have one or two scattered mitotic figures in different types of nevi, including young children or pregnant patients, for example. But when you start to get a significant number of mitotic activity in the dermal melanocytes, that argues for melanoma and a lack of dermal melanocyte maturation. So again, go back and review what it means to have maturation. Typically, compound melanocytic benign nevi have type A, B, and C melanocytes. If you're not having that normal maturation pattern, where instead you have large atypical melanocytes at the deeper aspect of the melanoma, that argues against a benign melanocytic proliferation. So here are some histologic classifications of invasive melanoma. So Lentigo maligna melanoma is the term for an invasive melanoma that looks like Lentigo maligna on top, but it has an actual vertical growth phase and there is invasion. So this is the next step beyond melanoma in situ Lentigo maligna type. Okay, so Lentigo maligna melanoma is by definition an invasive melanoma. Superficial spreading melanoma is probably the most common melanoma type that I sign out. This is essentially a melanoma that has an invasive component, but it also has a very large junctional component as well. So this is kind of the next step beyond superficial spreading melanoma in situ. So you have prominent junctional phase or radial growth phase with pagetoid spread, contiguous growth, and then you also have an invasive component. Nodular melanoma is not just when the melanoma forms a nodule. It's whenever there's a prominent vertical growth phase without a significant, at least appreciable radial growth phase. So this means that the melanoma just kind of started out and in its very beginning delved deep into the dermis and then formed a nodular proliferation. You usually will not see multiple reedy ridge span involvement of the nodular melanoma, or else that would be more of a superficial spreading melanoma with a significant vertical growth phase. Nodular melanoma, by definition, is truly that it just went right into the dermis pretty early. And so you'll find this expansion of the papillary dermis where it started. You may find even a collarette. You may find ulceration, which makes it difficult to truly say if there was either, yes, a prominent radial component or not. But nodular melanoma, by definition, cleanly is that it has a very small focus of junctional involvement. Acral lentiginous melanoma. This typically involves a melanoma on acral or volar sites, such as the fingers, palms, the soles, the toes. And oftentimes, these proliferations do have a lentiginous growth pattern up and down the reedy ridges along the acral biopsy site. So there often is pagetoid migration, even in benign junctional or compound acral nevi. So this makes it challenging, and we'll go over that. But acral lentiginous melanoma oftentimes has specific genetic aberrations or more common genetic aberrations, such as KIT mutations and things like that, that make them somewhat special. However, unfortunately, acral lentiginous melanoma is diagnosed often at a more advanced stage and results in a very increased morbidity and mortality for patients, even patients of skin of color. Oftentimes, these patients are not aware, or the dermatologist is the first to really take a look at the bottom of their feet and truly look for this type of melanoma. And by that time, it's already advanced, unfortunately. So this is a very challenging type of melanoma. Spindle cell melanoma is composed of spindle cell melanoma cells that are mainly in your differential, along with spindle cell, squamous cell, and even atypical fibrous xanthoma. So oftentimes you can't tell it's a melanoma unless you do special stains. Desmoplastic melanoma also very related to that. So oftentimes desmoplastic melanoma is composed of spindled or epithelioid cells, but it has a prominent collagenous or sclerotic stroma around it. And these can be very tricky to diagnose. And so you'll want to look for a melanoma in the junction overlying that desmoplastic melanoma proliferation. And we'll get to some examples. Nevoid melanoma, unfortunately, is what keeps a lot of pathologists on their toes for making sure that they're not missing a nevoid melanoma, because nevoid melanomas essentially can look exactly like a nevus, a benign nevus. However, there are some subtle features that clue you in that it's not just a nevus, but it's actually a melanoma that looks a lot like a benign nevus. And we'll talk about that. And then there are some very really rare entities and types of histologic classifications of melanoma. We won't have time to go over everything today, but I will refer you to Whedon's textbook, as well as McKee and just many other derm path textbooks out there that do talk about the very rare subtypes of melanoma. Oftentimes, if you encounter something called melanoma not otherwise specified, it's because a melanoma didn't really fit neatly into any of these categories above. Lentigo maligna melanoma is Lentigo maligna that has progressed beyond the radial phase into the vertical growth phase. Invasive melanoma component is usually spindled, as opposed to more epithelioid or nested that you're going to find in traditional superficial spreading melanoma or nodular melanoma. That being said, you can have lentigo maligna on top, and then just one or two nests in the dermis that are cleanly separated from any reedy ridges, and that would be needing to be diagnosed as invasive, usually just to err on the side of caution to make sure that you're not under-interpreting lentigo maligna melanoma. It can be multifocal depending on the sectioning and the biopsy technique. So this is a not very subtle example of lentigo maligna melanoma. In contrast to the first clinical picture of lentigo maligna, which was MIS, lentigo maligna type, you can see here this has developed quite a nodular component. So you can see the asymmetry, the diffuse nature of the involvement across the entire left cheek, it looks like. If you biopsy probably the center of the lesion, you're going to find much more of an invasive nodular to spindle component. On the edge, you may actually find more of a junctional component. So it's important to go after clinically what looks to be the most involved, and that way it'll correlate more with the staging. You can imagine the difficulty, though, of planning for a surgical approach to this. So in many cases, it's going to be a collaboration between plastic surgery, Mohs dermatology. This patient would definitely be discussed at a tumor board, interdisciplinary tumor board, just to make sure that all different treatment considerations and surgical approaches are determined. So here is an example of lentigo maligna melanoma. You can see proliferation along the epidermal junction in a severely sun-damaged site, probably the face or the head and neck. You can see that the invasive component is mainly composed of atypical cells. You can't really tell, but you would assume that they're melanocytes because they're right below the junctional component. And you can see that there are some areas of the dermis which just show normal fibroblasts and abundant solar elastosis. So this atypical melanocytic proliferation actually pushed down and pushed the solar elastosis downward. This is your typical appearance histologically of lentigo maligna melanoma. You would measure the thickness from the top of the granular layer all the way down to the deepest aspect, farther away from the follicle, because you never measure Breslow thickness by the follicle. You always measure it in areas that are not associated with adnexal extension. Just another example of lentigo maligna melanoma. And here's what I was talking about with the nests and the dermis. So you can see now, if there were a bunch of reedy ridges around here and they were at the same level as this, then it would be difficult to call. But you can see here that there's an effacement of the reedy ridge pretty cleanly. And so the dermal presence of these nests actually do appear to be separate from the junctional proliferation. And so you can measure this as a thin melanoma here. You can also see these vertical vessels here, which looks to be like a scar type formation. And so maybe this lesion underwent some type of regression phenomenon, resulting in some fibrosis around the area. And then you have some invasion subsequently of atypical melanoma cells. Moving on to superficial spreading melanoma. It's the most common variant, as I said, most common site in men on the back. So I often double and even triple check the back on patients because this is the highest risk place for melanoma to occur, especially in sun-damaged patients. And this is the area of the skin that each individual patient cannot do a skin check on themselves. And so you really need to focus on these high-risk areas clinically. And I also take this information into account when I have someone who is older and it's a lesion from the back and the clinician is worried about melanoma. I will often do a more extensive workup of the site just to make sure that we're not dealing with the melanoma. The most common site in women are the legs. These are often flat, scaly macules or plaques evolving into a blue or black nodule. Clinically, my practice is actually biopsied melanomas that are undergoing an inflammatory response and a regression. It looks like a benign lichenoid keratosis on low power. And they often told me that it looked like a blue papule on the biopsy. Here you can see some clinical examples of melanoma. Asymmetric pigment distribution, overall asymmetric border, relatively large size, a blue to white color, uneven, just discoloration of 3 or more colors along the nodule or the papule. Superficial spreading melanoma involves tumor growth and continuity from one reedy ridge to another. That's characteristic. Remember, I said if there's a involvement of multiple reedy ridges by the melanoma, then that's superficial spreading melanoma. If it looks like a nodular melanoma, however, there's a lot of reedy ridges involved on the junctional, then it's probably a superficial spreading with a large or prominent nodular growth phase. In contrast to lentigo maligna, I won't say there's no sun damage, but I will say that there does not have to be extensive sun damage in these types of melanomas. Here you see asymmetry. The invasion is to the left of the follicle. So oftentimes you'll find just junctional areas, and then in other areas you'll find invasion. Here you see kind of, if you go on higher power to look for invasion, you'll find these atypical melanocytes coursing through the collagen. You'll find areas of pigment incontinence or melanin even around the proliferation. Oftentimes these are surrounding melanophages. They're not actually malignant melanocytes. So the histiocytes are taking up extra melanin pigment by the melanoma cells. You see overlying this prominent pagetoid melanoma and abundant contiguous growth. Oftentimes these will have pigment in the stratum corneum overlying it if it's been traumatized, or if there's just an abundant turnover of malignant cells producing a lot of stratum corneum pigment. Moving on to spindle cell or desmoplastic melanoma. These are often lumped together because sometimes it's difficult to separate the entities because there's such a prominent spindle cell component. The spindle cell or desmoplastic melanoma are usually on the head and neck. They are enlarging indurated plaques or firm tumors. They're frequently non-pigmented, which can make the clinical diagnosis quite challenging. And unfortunately, they're stubbornly recurrent. Pure desmoplastic melanomas uncommonly metastasize to regional lymph nodes. So if you just see a prominent spindle cell component without much of an epithelioid malignant population, those are less likely to metastasize to regional lymph nodes. If you see more of a epithelioid component, then unfortunately it's at a higher risk to metastasize to regional lymph nodes. Some believe that sentinel node biopsy is not warranted in this group. I tend to say that if you have a lesion that is thicker than 1 millimeter, then sentinel node should definitely be discussed. There are multiple different ways now that we can assess for risk of metastatic disease. And we'll mention at the end of the lecture Castle testing, which I don't have any stock in the company or interest in the company, but just there's a lot of interest among clinicians and pathologists to utilize that test to predict whether or not there would be a spread to a sentinel node or not. But if the patient's willing to undergo a sentinel node and you're around 1 millimeter, I would say that it's probably worth doing because there's uncertainty and even some sampling errors in terms of the biopsy once you get close to 1 millimeter. So here you see an ulcerated papular nodule in the face of a relatively young patient here. Again, this is more of a sclerotic or fibrotic looking plaque on the, looks to be the right, looks to be just lateral to the right eye here. They can be very sneaky, and that's because the melanoma cells are spindled. They can look like fibroblasts on the pathology. They may underrise or they may arise underneath a Lentigo maligna. And that's oftentimes how I'm going to clinch the diagnosis is I'm going to see a Lentigo maligna on top. There has even been diagnostic confusion with neurofibromas and desmoplastic melanoma because of the spindle cell component. However, with neurofibromas, you're not going to find melanoma in situ on top. We'll talk about the fact that immunohistochemically, neurofibromas and spindle cell melanomas have very similar immunohistochemical findings because SOX10, S100, those are positive in both desmoplastic melanoma and neurofibroma. And unfortunately, desmoplastic melanoma loses expression of other common melanocyte markers, such as melan or MART and HMB45. So you can't use the traditional melanocyte specific stains of melan or even HMB45 to help you in these types of melanomas. There is that PRAME stain that I mentioned, which is positive in up to a third, depending on some of the studies of desmoplastic melanoma. So if you do a PRAME stain and it's diffusely positive, I would say that that should increase your suspicion that you are dealing with a desmoplastic melanoma. Of course, with these, you're not going to make the diagnosis by yourself because you're going to need to show it to other pathologists as well, just to get a consensus before you sign out something like this. But have a high degree of suspicion, especially on the head and neck of sun damaged patients. And if you see an atypical junctional melanocyte proliferation in the junction, then you need to rule out desmoplastic melanoma before you can truly say. And I would oftentimes do PRAME in these because of the data that I just cited, and we'll talk about that. Perineural invasion, unfortunately, is also common. If I see perineural invasion, even if it's a pure desmoplastic melanoma, I think that the patient's going to end up getting a sentinel node because by that time it's pretty deep And that's just already a bad sign for the prognosis in general. So this is actually a better example of spindle cell or desmoplastic melanoma here, because you have a lot going on. But one thing that can make it tricky is you often have a lot of lymphocytes within the picture as well. So if you see lymphoid aggregates and you see a junctional melanocytic proliferation and you see a very busy spindle cell dermis, then doing your SOX10 stain will be vital. Make sure that to really clinch the diagnosis. You'll see contiguous growth along the junction in most cases, depending on the section, and you'll see diffuse infiltrative growth of atypical melanocytes. Here's another example of just how it looks almost like diffuse or lymphoid aggregates on low power. And you can see that they're, in some cases, are very fibrotic desmoplastic stroma, which is a part of the definition, obviously. You can see here on the left, mid-left side of this right panel, this diffuse, what appears to be a lymphoid aggregate that I was talking about. So often seen in desmoplastic melanoma. Here's another kind of on low power subtle example here from Elston's textbook. But you can see how this would be easily missed if you didn't have a high degree of suspicion. So there's diffuse spindle cells. From this power, you can't tell. You'd have to go in higher power and also do SOX10 staining, but these are malignant melanocytes intercalating throughout the dermis. Nodular lymphoid aggregates are shown here. And again, if you see this pattern, you know, and the clinician, it doesn't really matter what the clinician was thinking. If they were worried about a neoplasm, that's all you need. They may have not thought that this was a melanoma. They may have thought it was more of a scar or some type of morphiiform basal cell or something along those lines. But you really have to have a high degree of suspicion here. Again, higher power from Dr. Elston's textbook showing you just the cluster of concentrated atypical cells in the dermis, and then that nodular lymphoid aggregate. So as I mentioned, desmoplastic melanoma cannot be worked up with the HMB45 or Melanoma, and that's because, well, you will still do the stains to show they're negative, but by definition, the desmoplastic melanomas are SOX10 positive or S100 positive, but most often, almost always, negative for HMB45 or melanoma. Moving on to nodular melanoma, this is, as you would expect, a nodular, oftentimes polypoid, pedunculated appearance, usually dark brown, blue, or black. Here you see the nodule that has a wide area of ulceration on top. Again, it can look like a vascular lesion. It can look like a lobular capillary hemangioma or a pyogenic granuloma. Really, the differential for a red ulcerated papule on derm path is quite large. So this could be anything in your imagination. It could be a epithelioid sarcoma. It just really depends on what the final histology shows. So if this lesion is growing, it doesn't really matter. You're going to need to biopsy it and show what it is on histology. So the pure definition of nodular melanoma, and I think this is about the 5th time I've mentioned it in this lecture, is no significant epidermal component, so no significant radial phase. It may be symmetrical, and that's because it has such a prominent vertical growth phase. Some of the hallmarks of nodular melanoma include deep mitotic figures, but the number of mitotic figures in a melanoma is surprisingly low compared to what most beginners would think. So they would think that you'd be able to find lots of mitotic figures everywhere. Usually it's about 5 or so on average per square millimeter. And usually we'll go to 40x and we'll find an area of mitosis, and we'll start to count from there at 5 high-powered fields, and then add all that number together to get your number per square millimeter, depending on how your microscope is calibrated. But usually the mitotic activity is not as abundant as, say, a Merkel cell carcinoma, which you can have hundreds of mitotic figures in 1 square millimeter. So here you can see this nodular growth of atypical melanocytes. From low power, you'll be able to appreciate this expansion, and you can see an intact epidermis on top. Then you see the reedy ridges over here that are still intact. And so this is most likely a nodular melanoma because of the fact that it just has a prominent downgrowth immediately. It has this kind of a collarette architecture to it. In most of the nodular melanomas, I like to see absolutely no junctional melanoma here in the top part. So you have an effacement of the reedy ridges, so it's hard to say that you don't have any involvement of reedy ridges from low power. So you go to high power, you see that the overlying epidermis mostly looks like thinned out atrophic epidermis, but no melanoma in the junction there or in the actual intraepidermal compartment. Okay. So that's nodular melanoma. Now, if you have a big ulcer overlying this, then it's going to be hard to say definitively, is it superficial spreading or nodular? Of course, it doesn't matter at the end of the day because it's a very thick melanoma from the Breslow depth at least, but you can kind of see that it seems to be pushing halfway up and halfway down. And so you may not find lymphovascular invasion. You may not find any perineural involvement here. It may just be a big nodule of melanoma, but you'll still measure from the top of the granular layer down to the thickest part for your Breslow. If it's ulcerated, you're going to measure from the base of the ulcer down to the bottom part of the melanoma. We'll talk about the staging of melanoma on a separate slide. So one of the hallmarks of a melanoma is no maturation or dispersion. So you see that the top of the melanoma shows malignant large sheet-like growth, and at the bottom it looks pretty much the same. So as you go downward, you don't have smaller morphology of melanocytes, you don't have dispersal of melanocytes as you'd expect to see in a normal maturation pattern. Instead, you just have sheet-like growth of malignant melanocytes from top to bottom here. Again, on this higher power, you'll notice that there's not a significant amount of true neoplastic cells in the epidermis. Acral lentiginous melanoma, this is predominantly in type 3 or 4 or 5 Fitzpatrick types or other patients of skin of color, Asian American population, Hispanic, etc. It can occur in all patients. Let's just be clear on that. However, a lot of focus is on the fact that these are often found in patients that have more melanin production, and the risk of a development of acral lentiginous melanoma does not really depend on sun damage here. It's most commonly on the plantar foot and the heel. Rarely it is subungual, but subungual melanomas are found, and I've signed out several of them already in my practice, both at the VA Medical Center and at OU. These are present as irregular, gradually enlarging and variable pigmented macules. They can develop into papules as well. When you're looking on dermoscopy, you'll want to see that if you have prominent involvement of the ridges as well as the furrows, but even the ridges, that can signal to you that you'll probably need to do a biopsy because you can have atypical melanocytes that are more on the superior aspect of the dermal papilla reedy ridge there. And so you'll have involvement of atypical melanocytes, not only at the reedy ridges, but at the peaks and the furrows. And so you'll want to use your dermoscopic technique to make sure that you're getting that pattern in place before you do the biopsy to correlate clinically. However, these are really tricky on histopathology, and typically benign acral nevi can have some areas of pagetosis. And so you'll want to do some other types of tests maybe, or look at the overall architecture if you have any degree of suspicion whatsoever that there's some atypical architecture to these lesions on the biopsy. So with progression to the vertical growth phase, then these macules will turn into nodules, and oftentimes they will ulcerate. So if you have an ulcerated pigmented lesion on the bottom of someone's foot and they're an older person, then you got to do a biopsy right then and there. You got to convince them that we have to do a biopsy to make sure that we're not dealing with an acral lentiginous melanoma. Here you can see this irregular plaque. It's probably over 1 centimeter, just beyond on the widest axis here. It's a atypical, asymmetric, pigmented papular plaque, depending on the measurement. And this patient, regardless of age, if they said that this is a new area here, then you're going to want to do a broad shave to look at the junctional and as much of the dermal component as you can here. You can consider doing a punch biopsy, but I find that broad, deeper shaves are more informative. And remember that the thickness of acral skin is quite large, right? So it's easy to just get some stratum corneum and not a lot of epidermis or dermis. So you want to definitely get as much as you can. And it's a difficult area to do a biopsy, admittedly so. And so sometimes you may not get a great sample, and that's where some ancillary testing, including frame immunohistochemistry, I found to be pretty helpful as well. Just another example of an ulcerated, very bad looking acral melanoma clinically. So these are poorly nested and they contain confluent melanocytes at the dermal epidermal junction, many with paginoid spread, but less than in superficial spreading melanoma. So you don't always have to have a lot of paginoid spread either, which can make this tricky. Cytologically, the nucleoli are often easy to spot, and mitotic figures can be identified as well. Here you see a proliferation of melanocytes at the base of the reedy ridges here, and they start to cluster up in a lot of contiguity here, extending up the adnexal structures. You can see a little pagetoid area as well. Now, admittedly, this can be very tricky because you see that most of the melanocytes are down at the base of the reedy ridge. So I often will do a PRAME stain on this, as well as even maybe a P16 stain. Oftentimes, PRAME is diffusely expressed in acral melanoma. P16 is sometimes lost in acral melanomas, but in a head-to-head, PRAME seems to be more helpful. Of course, you're going to want to look at all sections of the epidermis that you have. In this case, I'd probably even cut deeper sections just to make sure that there's no better representative example here. This is a really nice example to show you the contiguous growth of atypical melanoma along the dermal epidermal junction, not only at the base of the reedy ridges, but even at the peak here above the dermal papilla. So this is where you get that lentiginous term because of the broad end-to-end, up and down growth pattern along the dermal epidermal junction. You can see some areas of pagetoid as well. Not super extensive pagetoid upward migration here. The dermis, it's difficult to see, do you have some atypical melanoma cells in the dermis or not, or is this just mainly some type of fibrosis happening with proliferation of vessels? So I would do a SOX stain and a PRAME stain just to look and see if any of these dermal cells are positive, because this proliferation is clearly away from the plane of the reedy ridge here. So this would be invasive if these turned out to be SOX positive. If they were SOX negative, then this would just be a very prominent melanoma in situ that's not invasive of acral lentiginous melanoma. Here you can see enlarged asymmetric junctional nests that are expanding at the base of the reedy ridge, prominent pagetoid spread, as well as a prominent lentiginous component here. If you go on high power, you should be able to appreciate that these melanocytes show some nuclear pleomorphism. However, it's not really that far outside of what you can sometimes see in a normal nevus as well. in my experience, when you have the architectural features to make the diagnosis of melanoma, even the bland looking melanocytes will be diffusely PRAME positive. And again, I'm not using PRAME as 100% here. I'm just saying that in a high number of acral melanomas, even the bland looking, cytologically bland looking melanocytes can have an immunophenotypic atypical expression of antigens that are associated with melanoma, such as PRAME or HMB45. Now, this wouldn't be that doing an HMB45 would not be very helpful for a predominantly junctional proliferation, because HMB45 is usually expressed at high levels in junctional and superficial dermal melanocytes. And usually the benign immunophenotype is that you're going to have decreased expression with descent. However, PRAME is usually not expressed at all in benign acral melanocytes, or maybe sparsely, but if you found diffuse PRAME expression, that would be a worrisome finding. If there's other doubts after immunohistochemical or architectural assessment, you can send this for FISH, fluorescence in situ hybridization, to look for gains or losses in foci often associated with melanoma signatures, as well as even next generation sequencing to look for common mutations in melanoma associated genes. You can look for mutations in TERT. You can look for mutations in BRAF B600E or BRAF B600K. You can look for KIT mutations. That would be very important to look for in acral melanoma as well. What are the melanoma prognostic indicators? So clinically, age, sex, and the site of the primary tumor can play a role. So the prototypical worst case scenario is an older male on the back or the upper arm, the scalp, or the neck, or in an acral site. In the study I did on acral melanomas, age was very associated with the likelihood that it was a melanoma. So the older person with a growing pigmented lesion on the foot, for example, or any acral surface will become worrisome, and the need for a biopsy is very high. Other important things to look for on the histologic assessment will be the tumor thickness or the Breslow depth, the Clark level of invasion, the growth phase, the mitotic rate, whether or not there's ulceration, lymphovascular invasion or perineural invasion, presence of regression, presence of tumor infiltrating lymphocytes, and macrosatellitis as well. So macrosatellitis is something that you'll have to have a larger biopsy for, or an excisional specimen to be able to assess. So let's talk about how to measure Breslow thickness. So it's the single most important prognostic indicator, all things considered. Deeper tumor has more access to the lymphatics, as common sense would dictate. The thinner the tumor, the better the prognosis, as common sense would dictate. It's also used for staging here. So the Breslow thickness of less than 1 millimeter often correlates with a 95 to 100% survival rate over 5 years. You can see the survival rate decreases incrementally as you go down the columns here, or down the rows rather here. So 1 to 2 millimeter of thickness, 80 to 96%, 2.1 to 4 results in 60 to 75%, and greater than 4 millimeters is often associated with less than 50% 5-year survival. So how would you measure the Breslow thickness here? You would go from the granular layer down to the deepest aspect of the tumor. You can see that on this specimen, there's a curvature to the epidermis. So no matter where you measure it, it's probably going to go down to about the same depth. But I often measure in multiple areas and see which is the thicker area. If there's a lot of inflammation, sometimes I'll get a sock stain just to look and see where the deepest melanocyte population is, and measure it based on that as well. And I correlate that with the H&E staining. If it's ulcerated, you're going to measure from the base of the ulcer to the deepest extent of the tumor. So the base of the ulcer could be somewhat subjective. And so I would typically measure from the area that you can see the melanoma cells present just outside of the ulceration there. And if it will detect basically a thicker depth, depending on where you measure it, I will often make sure that I'm measuring to include a higher stage, because you don't want to minimize the stage if the reality suggests that the ulceration could include some melanoma cells that you cannot actually see. And so you'll definitely want to define what the base of the ulcer is, and that typically will involve the first dermal component that you can actually see. If you find some fibrin deposition, you can probably measure from that fibrin deposition down to the deepest aspect. There could be some subjective decision making when you're measuring from the base of an ulcer. So showing colleagues is also a good idea to see if you can have some consensus, especially if it affects the staging. Along the lines of staging, typically, if you look at this, ulceration here, and I'm going to circle this area, will result in a B designation at the end of the T classification. So if you have ulceration, you're going to end up adding a B to the stage, okay? So looking up at the primary tumor or T classification, if you have something that you cannot assess because it's severely regressed or it's the sample's heavily fragmented due to curettage, that's going to be a PTX. There's no evidence of primary tumor invasion. That's a T0. If you have in situ melanoma, that's a TIS. T1 includes 1 millimeter or less in thickness, but jump down to this subclassification here of T1. A involves a Breslow thickness of less than 8 millimeters without ulceration. However, if you do have between 0.8 and 1 millimeter, even without ulceration, you're going to have a B to the end of that T1. So T1B, if it's 0.8 to 1, and you don't need ulceration. But no matter what, if it's less than 1, but it could be 0.8 to 1, it could be less than 0.8, it doesn't matter. If it has ulceration, it'll be a PT1B. Beyond that, it's somewhat easy to remember that 1.1 to 2 will be your T2 stage, and then your T3 will be 2.1 to 4. Again, without is an A, and with ulceration is a B. Greater than 4 millimeters is a T4. If there's a sentinel lymph node excision, then what you'll do is you'll take into account how many lymph nodes are involved, and you'll place the findings into this N1, N2, or N3 category. It can be a little tricky to do this based on just the slides alone, and sometimes you'll have to get clinical information as well. So 0 to 1 node involvement will be clinically occult detection. B will be clinically detected, and C will be no nodes involved. However, there was some detection of MSI. So that brings us to the concept of MSI, which is typically a combination of either a microsatellite, a satellite, or an in-transit focus of melanoma between the primary site and the collecting sentinel node. If you have 1 to 3 nodes involved, and that can be separated into A, B, and C. So A would be 2 to 3 nodes clinically occult, no MSI parameters. B would be 2 to 3 nodes clinically detected, no MSI parameters. And C would be 1 node clinical or occult and MSI present. So being able to just diagnose metastatic melanoma and determining how many nodes are involved on the sentinel node excision plus the clinical presence of any other intransient detection is going to be able to help you classify the final end stage on this. And then that's going to be able to help you correlate at least to the overall clinical and pathologic staging. Moving on to metastasis, if you have no detectable evidence of metastasis, that's M0. If you have M1A, that is metastasis to the skin, subcutaneous, or distant lymph nodes. M1B will include metastasis to the lung. M1C will include metastasis to all other visceral sites, and M1D will include metastasis to the brain. Sometimes different considerations will include serum lactate dehydrogenase to incorporate into the M category, as shown below here. And so if it's normal, then that's going to be an M1, either A through D, depending on the above designations, and then a 0. Whereas if it's elevated, then you'll have an M1A through D with a little 1 added in parentheses. So taking into account all of these parameters, you can get an idea of the clinical staging, and this would allow you to bump up staging. So you can see that clinically, stage 3 is going to also correlate clinically with the pathologic stage of 3. And that's when you actually have some node involvement as well. So having a T3, for example, B would be a stage 2B overall, but the actual stage would be a T3B in terms of the T. And when you go down to looking at stage 3 overall, that's when you have a correlation from the clinical to the pathologic of having node involvement. And then when you have metastasis, that's going to be your stage 4. Clark levels is still used in templates, but it's not as used as much as determining prognosis, but it's useful to be able to assess it for the melanoma template and reporting. And so Clark level 1 includes intraepidermal only. Clark level 2 involves into the papillary dermis. Clark level 3 is when the melanoma starts to fill the papillary dermis, but it's not really significantly beyond the papillary to reticular dermal interface. Stage 4 is when you enter more into the reticular dermis. Stage 5 is when you actually make it all the way to the subcutaneous tissue. There is a little bit of discrepancy among dermatopathologists on calling it 3 or 4, because it's a little bit subjective when you're looking at the interface between the papillary and the reticular dermis. If you find any cells at all in the reticular dermis, that's going to be a stage or Clark level 4. And so many institutions will often report out a Clark level 4 because it's pretty easy to get to the reticular dermis. In fact, the papillary dermis here, some could argue is the border is even a little bit higher than that, as depicted in the cartoon here. So, but the most important thing is that these are always going to come with a Breslow thickness. And so whether or not someone calls it a 3 or a 4 on the Clark level, it really comes down to the Breslow thickness. Ulceration is associated with significantly increased risk for metastasis. It's used for staging. I will say a note about ulceration is I like to see a complete loss of the epidermis and some areas of ulcerative change and actual reparative change in the area. I don't want to see stratum corneum or any keratinocytes in an area of ulceration. So if I have subcorneal hemorrhage, but if there's still a stratum corneum in there, I'm not going to really call it a straight up B designation for ulceration. if I still have some stratum corneum. However, there have been cases where I've had a designation of ulceration given to a case, and that was because it looks like there's a lack of epidermis in an area, but the stratum corneum is still there, which is technically not ulceration. Nevertheless, if it's a super small focus, and the rest of the epidermis is intact, you could argue that the designation of ulceration could actually emphasize ulceration. And so even just commenting on the level of subcorneal hemorrhage and saying, this is what is seen, describing what is seen is actually useful. If there's a large area of ulceration, it can be useful to just describe the width of the ulcer. But of course, not all bees are created equal. So you may have a very small focus of ulceration or a very large focus of ulceration. And I find that just describing what you see is often better. At the end of the day, staging is really just for prognosis, as well as looking at the effects of treatments and stratifying patients into different treatment groups or prognostic groups. And so being as accurate as possible in the staging is always desired. There can be discrepancies among consensus on ulceration as well. So if the clinical picture suggests that it was ulcerated, and you have a inflammatory crust overlying the melanoma, that means that the dermis was probably breached somehow. And that's how you got the leakage of blood components out into the extradermal space. Tumor infiltrating lymphocytes, they are usually a hallmark of host response. And you can see that in these cartoons here, the melanoma on the top left has absent tumor infiltrating lymphocytes. The right top panel, it shows that there are some lymphocytes, but they're not infiltrating into the tumor. So that's technically not present. If you've got some areas of involvement of infiltrating lymphocytes, but not the diffuse tumor, that's called non-brisk. If you've got diffuse involvement of intratumor lymphocytes, that's called brisk. And if you have even just some infiltration on the outer edges of the tumor and it's kind of spread throughout, some people would argue that that's also brisk. It can be a little bit subjective, again, also depending on the sectioning. But again, this is oftentimes a supplementary aspect of a synoptic report, and I try to include it if I can assess it. What do we mean by regression? Regression is scar-like areas of dermal fibrosis within the tumor itself. Usually it contains lymphocytes and decreased numbers of atypical melanocytes. So even if you do your stains, you may find that there's a decreased number of detectable melanoma cells, but on the adjacent areas, you should find some melanoma in situ at least, or even invasive melanoma to the outside parts of the regressed areas. You may find apoptotic cells. You may find melanophages that are eating up the pigment from the regressed melanoma and the basement membrane that was present before. Clinically, these regressed areas look like gray, white, or pink macular areas within the overall melanoma itself. So if you are a beginner and you hear someone say, this looks like it could be melanoma with regression, clinically, that they're referring to this gray, white, pink type macular area within an overall suspicious lesion. Regression is associated with a worse prognosis. This means that the melanoma has probably waged a war with the immune system, and the immune system's won some of the game, but not all of it. And so that might be why it's associated with the worst prognosis, is that the immune system came in, tried to kill off melanoma, and it ultimately failed because there's still residual melanoma around the regressed area. So that's probably why it's associated with a worse prognosis, because it's indicating that metastasis has probably already occurred, or that it was deep enough to set off the immune response in general. Some recommend sentinel lymph node biopsy for thin melanomas with greater than 50% regression, and this is because of that issue of it being associated with worse prognosis. Now, this can also be a little bit subjective, defining greater than 50% or less than 50% of regression in a melanoma. So it's always good to get a consensus as well as deeper sections to try to nail down that percentage. Here you can see an effaced reedy pattern and diffuse melanophages and fibrosis in the dermis. Now, here it's actually hard to appreciate any junctional melanoma, and if you did a melanocyte stain, you may not find any detectable melanoma cells. This may just be all small blood vessels and diffuse melanophages here, but no actual melanoma cells. This is a type of process called tumoral melanosis, which means that there was probably a melanocytic lesion there. However, it's not detectable on current sections, and deeper sections often will even fail to show a legitimate lesion still persisting. And so that's often a phenomenon of tumoral melanosis, where you just have diffuse sheets of melanophages in the superficial dermis. Here you can see some scattered melanoma cells within a background of a scar-like fibroblastic stroma and areas of scattered melanin pigment, which could include melanocytes or melanophages, depending on if they were SOX10 positive in the nucleus. Another example of here you can see some focal pagetoid presence of melanoma here, and then this just diffuse presence of melanophages within the dermis running parallel to the surface here. So again, tumoral melanosis. Mitotic rate is another important aspect that we measure. It's associated with a significantly increased risk for metastasis, as common sense would dictate. The account is usually reported as millimeters squared. Of course, more mitotic figures found equals a bad prognosis. Other additional negative prognostic indicators, the presence of microsatellitosis or satellitosis here. It's usually a distinct tumor nodule that is located at least, but oftentimes greater than 0.05 millimeters within 2 centimeters of the main tumor. So if it's greater than 0.05 millimeters of a collection of tumor cells and it's within 2 centimeters total of the main tumor, that's microsatellitosis. Now, you obviously, if you have a biopsy that's less than 2 centimeters from the actual tumor, you're not going to be able to tell that. So oftentimes this comes into play on excisions. It's used in staging. Again, as I mentioned, if you have the presence of a microsatellite, then you're going to have to take that into account in your staging. Lymphovascular invasion and perineural invasion as well, as common sense would predict, are important negative prognostic indicators. Diagnostic dilemmas: is it a nevus or is it a melanoma? So there is no 100% perfect test for melanoma. You have to take into account architecture, immunohistochemistry, and molecular testing. Common tests today include fluorescence in situ hybridization, which looks for gains or losses of particular chromosome loci to predict melanoma signature. We won't get into the ins and outs of fluorescence in situ hybridization. You could have a whole lecture on FISH, but it is important to know that it is an option, and sending to a laboratory that does FISH, validated FISH, to make sure that lesions of suspicion don't have a melanoma signature, gains and losses of important loci. When you want to look at a comparison between a nevus versus a melanoma, thinking about circumscription, of course, the nevus you would expect to be symmetric with sharp circumscription, whereas with a melanoma, it's going to be variable in terms of its symmetry and circumscription. Obviously, the size of a nevus is usually going to be smaller, and a melanoma is going to be larger. Dermal epidermal junction architecture will include well-nested melanocytes in nevi. However, non-nested melanocytes usually outnumber the nests in melanoma. The shape of the junctional nests are often round to oval in benign nevi, but in melanoma, they're usually irregular. You'll find a lot more buckshot scatter of pagetoid cells in melanoma as opposed to in nevus. This is a chart from Elston for your reference here, and it just summarizes the maturation that we talked about, failing to mature in melanoma, failing to disperse normally in melanoma, and failing to gain smaller size as you go down into the dermis in melanoma. You have often larger cells and larger nests. Variable mitotic activity in melanoma, variable pigment. HMB45 is often very positive at the base of a melanoma. And Ki67, also known as MIB1, is very positive in proliferating melanocyte or proliferating melanoma cells. So usually it's, if you find something greater than 10% of a proliferation index with Ki67, that would be worrisome. S100A6 is listed here in the chart in Elston's textbook. I usually don't use S100A6 anymore, but Spitz nevi, which we have introduced in other lectures, often will have an immunoprofile different than melanoma. So with Spitz nevi, you'll want to see, of course, you're going to find SOX and melanate positive cells. You don't want to see a heavy involvement of HMB45 and PRAME in Spitz nevi. However, a recent paper by Dr. Coe and Dr. Billings at the Cleveland Clinic showed that the loss of P16 is much more predictive in the presence of, a worrisome Spitz lesion compared to diffuse PRAME positivity. Often you can have diffuse faint PRAME positivity and a proliferating spitzoid neoplasm that's not spitzoid melanoma. But a loss of P16 sets off a more worrisome immunophenotype. So a brief bit about melanoma and immunohistochemistry. I don't use S100 much anymore because it marks dendritic cells. It's a very all over the place stain. It's cytoplasmic staining. It's not very clean because it highlights so much in the junction already among normal melanocytes, normal Langerhans cells. So I usually don't use this much anymore. Of course, it will be positive in melanoma. HMB45 will also be positive in most melanomas, except the desmoplastic melanoma. And keep in mind that blue nevi, particularly even cellular blue nevi, can have abundant HMB45 expression. And so it doesn't mean that it's a melanoma if it has diffuse HMB45, if it's a cellular blue nevus. That's one very important exception. Cytoplasmic staining for HMB45 is usually seen in the junctional and superficial dermal melanocytes, but lost in the deeper melanocytes. In melanomas, it's positive all the way down. This often will also correlate with diffuse PRAME staining, which is on the bottom right here. PRAME is known as a retinoic acid signaling inhibitor, among other things. I will do a separate lecture. The second half of this lecture will be recorded and posted separately, but we will focus on PRAME as a special immunohistochemical tool that is becoming more and more utilized across various institutions, including my own practice. HMB45 and melanate both are lost in desmoplastic melanoma. Like I said, PRAME is detectable in some studies up to a third of desmoplastic melanomas. There may be higher detection in different cohorts, and studies are ongoing. SOX10 will stain the desmoplastic melanoma cells, as well as S100. Keep in mind that SOX10 also stains Schwann cells, so it can be present in neural tumors. SOX10 is a nuclear stain, and so I find it to be very clean when you're looking at melanocyte density. When looking at diffuse sun-damaged skin and trying to rule out melanoma in situ, if you do a SOX10, you'll often find very close, clustered, contiguous growth of the melanocytes. However, PRAME stain is often mostly negative, maybe scattered here and there positive, but much less than probably 70 per square millimeter. And usually if you just have 1 out of every 10 or 20 melanocytes staining, that's usually not indicative of melanoma in situ in terms of the PRAME profile. And we'll get into more in that in the additional PRAME lecture. Additionally, you can do a Melan-A coupled with a Ki-67 double stain to look for proliferating melanocytes. So I'll often do a Melan-A Ki-67 double stain. And if I see that even greater than 10% of cells positive, I'll become more worried and I'll do additional immunohistochemical stains. I'll also always mention this in the report. Even if it's a benign lesion, I will mention the associated or the approximated proliferation index. Usually in nevi, you have less than 5% of cells being positive for Ki-67. In slam dunk melanomas, it's as high as 25% of the cells are positive. Interestingly, in most melanomas, even if you only have 25% of Ki-67 positive cells, most of the cells, greater than 95% of those cells, are going to be diffusely and darkly PRAME positive in the nucleus. So it's interesting to say that Ki-67 may reflect proliferation actively in non-mitotic cells, whereas PRAME is diffusely positive, indicating some type of overall activation among the entire population. P16 tends to be lost in melanoma and retained in benign melanocytes, but this is not 100%. And a good example of that would be a study that I did on acral melanomas, and I found that plenty of acral melanomas still had a lot of P16 positivity, but they were architecturally melanoma in situ, they were architecturally acral melanoma, and they were clinically and pathologically acral melanoma, diffusely PRAME positive and diffusely Ki-67 positive, high proliferation rate, diffusely H&B positive, and in some cases even molecular supported the diagnosis of acral melanoma, but P16 was still retained. So don't rely only on P16. Remember, I said P16 loss is more relevant in spitzoid neoplasms, and a loss of P16 is more worrisome. Cyclin D1 has been shown to show great full thickness positivity in 60% of melanomas. I personally do not use cyclin D1 in my workup of melanoma whatsoever. A word about melanoma FISH, as I mentioned. This is a technology where you can look for the aneuploidy, which is chromosomal gains or losses. These FISH probes target commonly gained and lost chromosomal loci with a high sensitivity and specificity and distinguish melanoma from benign nevi. So you'll want to look for a gain in RREB1. You'll want to look for a loss in MIB. You'll want to look for a gain in CCND1, which is where that cyclin D comes from. You can also look for a loss of CDKN2A. That is the gene that codes for P16. And you'll want to look for a gain in MYC, MYC. And again, that shows you which chromosomes these are on here. So chromosomes 6, 11, 8, and 9 are the chromosomes of interest. And we have these centromere markers to help us spot the chromosomes of interest. So you have to have a validated FISH access through whatever lab of choice. I trained at the Cleveland Clinic, and we had FISH available at the Cleveland Clinic. Many other places, including Mayo, have access to it. And here in Oklahoma, we are going to be developing that as well. Sentinel lymph node biopsy in melanoma, as I mentioned, recommended for all tumors greater than or equal to 1 millimeter in thickness. This can be give or take depending on clinical scenario. As I mentioned, some people said that if you have tumors with greater than 50% regression, lots of mitotic activity, but still less than 1%. But there are some areas of invasion into the reticular dermis. then you might want to consider pushing for a sentinel lymph node biopsy, as well as presence of ulceration. So you have to take things into account here, but it is clear that there have been melanomas that have never been shown primarily to be greater than 1 millimeter in thickness that have had presence of metastasis. How is a sentinel lymph node biopsy done? So there is this blue colored dye injected called lymphozurin. It's injected intradermally into the primary melanoma or excision site. It goes via the afferent lymphatics to the lymph nodes. You can see that there are relevant lymph nodes here. And so that's why you're going to have sentinel nodes that may have more than one node in the actual area. And you'll have some irrelevant nodes as well. So areas that were not shown to take up that dye in the area. So those would be most likely left behind. You can see this picture here of the uptake of the blue in the lymph nodes. Those would be taken and assessed on histopathology for the presence of metastatic melanoma. So looking for metastasis in lymph nodes, you're going to be looking for subcapsular or intraparenchymal presence of atypical melanoma cells. These will often be positive for melan-A, SOX10, HMB45, and PRAME as well. There have been some studies that have shown that there's some findings that show that PRAME can be detectable in lymph nodes as well. And this is still trying to be worked out and understood completely. There will be more information on that coming in the future, I'm sure, with upcoming publications and studies. So more to be continued on PRAME in metastatic melanoma lymph nodes. However, there are some papers out that showed that PRAME is a good marker for confirming metastatic melanoma compared to a nevus. So you can have benign nevi that are present in lymph nodes. A lot of people don't realize that. A lot of beginners don't realize that you can have benign capsular nevi in a lymph node. And so being able to show that the benign capsular nevi is in the capsule, not within the parenchyma, being able to show that it's HMB45 negative will argue for a benign nevus. If it's HMB45 positive or even PRAME positive, that argues for a melanoma. Up to a fourth of lymph nodes can have benign capsular nevi in them. So it becomes very important to be able to definitively say that it's a metastatic melanoma and not just a nevus. Now, if you find melanoma in the true parenchyma, if you find atypical melanocytes on H&E staining and SOX and melan-A and HMB45 in the parenchyma, it's pretty much a metastatic focus of melanoma. So here is an example of a capsular nevus sitting in the outside capsule of the lymph node. So these are bland non-melanoma cells. These are just normal melanocytes that are on the outside of a lymph node. You can see they're small, monotonous population. Immunohistochemically, they would be SOX10 positive, melan-A positive, but they should be negative for HMB45. They should be negative for PRAME. Here's an example of showing that HMB45 negative staining. Here's a subcapsular melanoma. So this shows you that presence of HMB45. It's in the parenchyma of the actual lymph node proper here. So common markers in melanoma, as I mentioned, we already went over these. So I will stop here, and for the next lecture that I'll record over the next few days and post will be to go into a little bit more deeper knowledge dive of what PRAME is and how it relates to current diagnostic workup, some of the pitfalls of using PRAME because no stain is perfect, and understanding what are the potential uses and what are the open questions still out there. And we'll also compare PRAME staining to the molecular test results as well, some of the studies that have been done. So thank you for your attention, and we'll stay tuned for the Talk on praying.